right, good morning, everyone. Thank you so much for coming to our workshop this morning, to our Lungs and Beyond workshop. My name is Allison. I'm from the University of British Columbia.
Hi, I'm Sid Kapnatic from the University of Washington.
Just a reminder of the format of the workshops. This talks will be about 15 minutes each, and we'll have 5 to 7 minutes for questions thereafter. We have a very exciting workshop planned for today with some really important talks that I know me personally, and I'm sure lots of other people have really been looking forward to some of the results that are going to be shared. We're going to be looking at adherence with ETI and clinical outcomes, looking at modulator therapy, extra-pulmonary outcomes related to modulator therapy, and importantly, maternal and fetal outcomes related to CFTR modulator use. Presentation disclaimer: unless explicitly stated, opinions shared by presenters do not necessarily represent the views of the CF Foundation. The Foundation supports NACFC, but does not generally review presentations in advance. The information provided during this conference is intended to be educational and informational. Attendees are encouraged to consult medical professionals for all healthcare decisions. And neither Sid or I have any conflicts of interest to disclose. Without further ado, I'd like to invite our first speaker. Dr. Paul McNally is an associate professor at RCSI University of Medicine and Health Sciences in Dublin, Ireland. He'll be giving us 2 talks today, the first of which is titled Adherence to Elexacaftor, Tezacaftor, Ivacaftor and Clinical Outcomes in People with Cystic Fibrosis, the RECOVER Study.
So sorry to those of you who are expecting Sharon, this is the wrong talk, this is the liver talk. Our pharmacy PhD student, Sharon Sutton, has done all this work and couldn't travel, unfortunately, so unfortunately you have me given this. So I'm not an adherence, I haven't been an adherence researcher up until the last few years, and it's a tricky area. It doesn't attract a lot of attention, it's not very sexy or exciting, but it's nonetheless really, really important. And so as part of our overall study, we were very keen to look at adherence to ETI because it's such an important treatment. Okay, here's my disclaimer. Okay, and here's my disclosures. Okay, so we know in chronic diseases overall that adherence to therapies is poor, independent of what disease you're talking about. And in a lot of diseases, there's a strong link between poor adherence and worse outcomes. But one of the problems is the tools we have to measure adherence are not great. So first of all, you've got self-report, and as we can all imagine, if you know anything about psychology, that's not very reliable. We have medication possession ratio. So if you're meant to get a box of tablets once a month, you're meant to get 12 in a year. If you pick up 8, that's 8 out of 12. Your adherence is 8 out of 12. So we can measure that over a longer period of time. It's not very detailed. And then we've got direct measurement, where you actually directly measure the adherence, somebody taking the tablet. This is, as you can imagine, tricky and can be quite a difficult thing to put into practice. That isn't really used that much in clinical medicine, but it is in things like clinical trials. So we know that ETI, you've seen it on multiple presentations in the conference, delivers very potent clinical effects, and it's a really, really obviously important medicine and group of medicines. So it's important that we understand adherence to it, and we understand what's the impact of adherence to it. And importantly for us, when we were designing the study, we really wanted to know what was the relationship between adherence and outcomes, because that's a very, very important thing to establish to start the conversation. So the RECOVER study is a broad, multi-spoke study in 8 sites in the UK and Ireland, with lots of different outcome measures. I'm just going to refer to the few that I'm talking about here today. So for adherence, we collected self-reported data with a validated tool, medication possession ratios by figuring out what they were prescribed and then what they collected from their pharmacy. And in the Irish sites, this wasn't delivered to the home. You had to go and actually collect it from your pharmacy, so you collected it when you were ready to collect it. So it was a good representation of adherence. And then we used a MEMS device for direct measurements. This is medication event monitoring. So it's a digital pill bottle where you decant the tablets into it, and every time you open it, it sends a signal. This was universally unpopular, and in fact, we have very little data on it because everybody dropped out of this phase of the study. Nobody liked it, primarily because they couldn't see the blister pack, they couldn't see what they'd taken. We have a range of pulmonary outcomes, including LCI, measured by nitrogen MBW. We have BMI and weight Z-score, and quality of life using CFTR respiratory domain. So what do we know so far about adherence? So this is data from Recover showing that self-report dramatically overestimates adherence compared to medication possession ratio. So the darker lines there you see, as we go across the slide, modulators, Dorniz alpha, hypertonic, azithromycin, pancreatic enzymes, and asthma inhalers. And the darker bars are self-report, and the lighter bars are medication possession ratio. So we know for certain that medication possession ratio doesn't overestimate adherence because you can't take more than you pick up. So you can see across the board here, self-report is optimistic to say the least. And so we can't really use this to look at outcomes. Using our MEMS devices, at six months we had 16 participants left. So we've data for a full 6 months on only 16 people. And the absolute adherence to morning ETI was 82.7% and to ivacaftor in the afternoon, 83%. So about 4 out of 5 is the directly measured adherence in the first 6 months of ETI therapy. And this is after all the excitement about the drug. So we expect that probably would reduce a little bit over time. And at the same time, our medication possession ratio was telling us it was about 90%. So we know from other disease areas that direct measurement, that NPR overestimates direct measurement. But even using NPR over 2 years, we showed this data here last year, that hypertonic saline, the adherence to hypertonic saline and Dorniz alpha significantly reduces after the initiation of ETI. And that's not a surprise to anybody from personal practice and also from data that we've seen. Looking at adherence to modulators, and the rest of the talk really is just about modulator adherence. So the adherence to dual modulators was 84.5% in the year prior to ETI. It was 92.6 at 1 year and then 81 at 2 years. So there's significant changes year on year in adherence. And certainly we noticed this in the data that we, in our database, between 1 year and 2 year, pretty much none of the outcomes changed except sweat chloride. There was a statistically significant increase in sweat chloride between 12 months and 24 months. This is the only thing that changed. And so we were wondering, is this related to adherence? So as we said, NPR was calculated from pharmacy refills, and then we looked at it in 2 ways. Obviously, because NPR is over the average of a year, we could either look at NPR for year 1 and then the outcome at 12 months, and then NPR for year 2 and the outcome at 24 months, or we could average the adherence over the whole 2 years and look at the outcome at 24 months. So I'll present data on both of them. We also have a simple correlation matrix, just looking at the adherence and outcome data on its own, and then we fit it into our mixed effects model. So this is data for the unadjusted correlation. So again, what I'm showing you first here is the mean NPR over 2 years and then outcomes at 24 months. And so what you can see here, it's a little bit surprising in that we do have some very significant p-values in these correlations, but for some unexpected outcomes, not some of the core outcomes that we would expect. And when we look here at the Pearson correlation matrix, very, very light. So although there are some statistical correlations, they're not very clinically significant. So then when we look at the data using time variable adherence, so that's first year adherence, 12-month outcomes, second year adherence, 24-month outcomes, we get a different story, much stronger correlations and also, more significant correlations and also much stronger relationships. Now, we only got this data last week, and my first impression was, wow, that's great. And then my second impression was, that's a bit too good. Very significant correlations in all of our outcome measures, and it's not really what we expected. So you've got to remember that this is just a straight off unadjusted correlation with outcomes and NPR, a time variable NPR. People still hear me? Yeah, sorry. The sound has changed for me. And so the next important step was to put this into our model, the mixed effects model, which already has time trajectory built into it and a genotype trajectory, trajectory between the F5 homozygotes and the minimum function group built into it already. So the two standard things that we see in this is that there is a strong relationship between time varying NPR and both sweat chloride and LCI. So they're strong in terms of the absolute values and also the statistical significance. We've less impressive data on small airway function, BMI Z-score, and CFQR, but surprisingly that's in the mean outcomes rather than, or the mean adherence rather than time variable outcomes. So then the next question we had was, so what does this mean in terms of effect size? Because you can have a kind of a strong statistical relationship, but we really need to understand what the effect size, what effect size this would relate to. So using the model, and again, this is data on 12 and over, the 12 and over group. We don't have the 6 to 11 data in this yet. So we'll have much more data points in the future. But our model suggests that a 30% reduction in NPR would lead to an increase in sweat chloride of 4.3. And the same 30% reduction in NPR would lead to an increase in LCI of 0.6, which certainly for the LCI, that's approaching a minimal clinically important difference. And I think a clinically relevant difference. So in conclusion then, we've shown that adherence to ETI reduces over time, even in the first 6 months and the great excitement of a new treatment. The directly measured adherence really was good at 80%. That's good adherence, but it's less than we thought it would be. We've shown a strong link between adherence and sweat chloride, so lower adherence, higher sweat chloride, and also a link between adherence and LCI. And we're presuming that's via the sweat chloride, but it may not be entirely. So our next steps then, we want to complete the data collection in the 6 to 11-year-old age group, and we also have imaging data that we haven't yet brought into the mixed effects model. So it'll be very interesting to see whether adherence affects or has a relationship with imaging outcomes. We are extending the RECOVER study, and I think it's going to be very important for us to look at adherence to ETI over the longer-term extension study and map that to outcomes. But I think the most important thing that we don't have, that we do need, is a practical, usable adherence measuring device. Because what we really learned from using the MEMS tool is, and that was quite a simple device, people really didn't like it because it messed with their blister pack. And I think people in general are interested in optimizing adherence, but very few of the tools that are being used have been developed with the community. They've been developed by somebody else for people, but not with people. So our team is working on this at the moment. We're trying to work with designers and people with CF to figure out how could we do this a little bit better. So first of all, I want to thank the participants and their families. This study is a lot of work, and so we have a huge team. I want to thank everybody. Jane Davies, my co-PI, who's giving another RECOVER talk in another session at the moment. Rachel Cregan at IFA, who are the project managers for the work that we do, and key participants in the studies. Mary Apker in the Brompton, who leads the UK side of things with Jane, and the CFF, who are our main funders. And we also have funding from CF Trust and CF Ireland. So I've finished with 1 minute and 37 seconds left on the clock. So happy to take questions.
Thanks.
Hi, Nancy Morrison from Nova Scotia, Canada. I'm an adult physician. We get every clinic, we get data on when the patients have refilled all of their CF medications. One of the problems I've always had is they refill them, but they don't take them. And with the fact that sometimes they'll say, oh, you haven't, you said you're taking such and such regularly, like azithromycin, but you haven't filled it in 9 months. Oh, well, that's because I had a lot of it at home. Well, obviously you weren't taking it if you had a lot of it at home. So we found this recently with a pair of sisters who, one sister sort of tattled on the other sister and said, well, I haven't been refilling my Trikafta because my sister's got stacks of it under her bed, so I've just been taking hers. So the refill information can be helpful, but the problem with sweat chloride that I've always said, because we talked about some of these ones that we think maybe aren't taking it regularly, do sweat chlorides. We're at the adult hospital. The pediatric hospital is just down the street, but sweat chlorides are done there. So I said, well, what's to prevent our patients from, they would sort of figure this out, from just taking their Trikafta for a week before their sweat chloride test. And then, you know, it looks like they're taking it regularly, because it's not like a hemoglobin A1C that averages something over time. And if you only had 72 hours of good blood sugars, it would still be high. So that's what I have a problem with. Maybe it's different with kids. They don't know what tests they're getting or whatever. But with adults, where we don't do sweats regularly, I just figure they're going to know that we're monitoring them. Any comments about that?
Yeah, so yeah, there's a lot in that. So first of all, yeah, that's the weakness of medication possession ratio. You can pick it up but then not take it, or you can take it out of the film but actually not ingest it. So, I mean, it is limited. So direct measurement is obviously much more reliable, but it's a difficult thing to do. For the Irish centres, the medication possession ratio is probably a bit more reliable, because the way it works is they don't get it delivered to them. They actually have to go and collect it, so that they'll only usually collect it once they've finished. So it minimises that a little bit, but it's not. Yeah. I mean, look, I'm not defending NPR. It's an imperfect outcome measure, but it's the best one that we have. And then secondly, in relation to the sweat chloride, yeah, you're right. There are outcomes that are very short-term sensitive, and then there are longer-term outcomes. And that's why we looked at all the various different, physiological readout like sweat chloride and the downstream organ effects. So when we look at imaging, that's going to be important, because that's a longer-term impact. And then I suppose, true, anybody knows they're going for a sweat chloride can, do up their buttons and take their medicines for a few days beforehand. But if we do it over multiple time points in large numbers of people, it's the best we can do to try and minimise that undue influence. So I think what we have is as good data as we can currently get, and even with that data, I think we're seeing a signal.
Thanks, Julian Thornton from Wales. We're mandated to do annual sweat tests for everybody on modulator therapies, and we've had a problem again with thinking that people will just take their treatments before they arrive. So we do it not at their annual review, but randomly. And we presented at the ECFS in Glasgow a surprising result that 30% of patients only had a drop in their sweat chloride of 10 from their pre-modulator level. Slightly unbelievable to put it all down to non-compliance. We were wondering how much of that is not taking the modulator properly, and whether we should, as a community, be concentrating on repeat training of how to take it properly, like you would for an asthmatic with a spacer. Their technique falls away. Is their modulator technique failing as well?
Yeah, it's a good question. In terms of the data we're looking at, that may affect your sweat chloride, so your readout, but not the raw adherence data. I suppose we haven't seen that in our data. While we're not looking at individuals, there might be fall-offs in individuals. The sweat chloride certainly up to 12 months was pretty steady over a large number of people. So, I mean, it's a really good point. The consistency and regularity and application of care is really important. I think that'd be a hard thing to study, Julian, to study it properly, because as soon as you start, that's what I've learned about it here, as soon as you start getting in and talking about it, it changes the outcome.
Sure.
Isabelle Sermet from Paris. Really interesting data linking the adherence and the LCI re-increase. So I was wondering whether in the model you also assessed not only the adherence to ETI, but also to other treatments such as physiotherapy or anal therapy, because we know that the patient auto-decide, the family auto-decide what to simplify, and this is also very variable in the time, so.
Yeah. We have that data, but we didn't put it into the model. What we were specifically looking at in this was just ETI adherence and outcomes, but we do have all of the NPR data for the nebulized therapies and all of the treatments. Now, for airway clearance, obviously you don't have NPR, so that's direct report. So we have that, but that's probably less reliable. But certainly into the model will go all of the NPR data for the other treatments. Yeah. Good thought.
And how about one last question?
Sure, I'll make it quick. John from St. John's. So did you tease out intentional versus non-intentional adherence or non-adherence? So for example, people forget to take it with fat or something. So they didn't mean to not adhere. That's kind of a form of non-adherence. Or, like the previous question asking person, when they pick up their medications, we know that they were dispensed to the patient. And I find it hard to believe that some of them, because we tell them how much it costs, and how lucky they are to have it. And I find it hard to believe that people would just not adhere. They just wouldn't take it. So then that makes me think they're intentionally not adhering because of adverse effects, which you then explore, or they're not intentionally adhering because they're just doing something wrong, which you need to explore.
Yeah, we presented data last year on it at barriers to adherence. Now, we haven't drilled down in a very detailed way to those barriers, but we used the validated questionnaires developed by Alexandra Quittner. So that data is still there and we still need to analyze it, but we haven't gone to that level of detail in terms of intentional or non-intentional adherence.
Yeah, and another consideration might be socioeconomic status as well, just in terms of people who may be conserving their medications due to cost.
For sure, yeah.
Well, thank you, Paul. Okay, our next speaker is Dr. George Marty Solomon from University of Alabama. He'll be speaking to us about the effect of ETI on long-term lung function and BMI trajectories.
I want to say thanks to Sid and Allison for the opportunity to speak today, and I asked Paul if he would like to just go ahead and give my talk. He declined the opportunity, so you'll have to listen to a slightly different regional accent for the next 20 minutes or so, so if that's all right with the audience. So thanks again for the opportunity to speak on behalf of the PROMISE investigators and the co-authors of this work about the longitudinal effects of lung function and BMI trajectories on ETI or Lex-TEZ-IVA. These are my disclosures, none of which are directly related to this presentation. So by way of background, ETI treatment results in remarkable clinical improvements for people with CF and one or more F508del CFTR alleles in short and long-term trials. Just one example of that data showing patients who crossed over into open label extension found remarkable improvements, both patients that have been previously treated with ETI in the randomized portion of these trials, and then those that crossed over to ETI treatment in the open label extension, remarkable improvements in lung function and BMI, two key outcome measures that we are looking at in the PROMISE study, which I'll discuss in a few moments. And these go all the way out to several years, indicating that perhaps these drugs have fully stabilized disease in these two core outcome measures and will result in no further declines in trajectory of these very key metrics for health in patients. Furthermore, if you look further into these papers, you'll find that in fact there's an reported annualized rate of change that's numerically essentially zero, indicating there's no further declines of lung function, which we know is a very key metric for cystic fibrosis. That, however, does not dispel the real-world impact of ETI on lung function and other important key outcomes like BMI and in this sort of real-world setting, especially in patients with severe lung disease that were not really tested in these types of control trials. So the real-world data, like Paul's already introduced with the RECOVER study and what the PROMISE study is doing, may help to answer those kind of real-world questions a bit more for us. The PROMISE data, which has already been published, suggested that in fact that these real-world settings can recapitulate many of the key findings that were found in the original clinical trials leading to ETI approval, and have made a few interesting correlations, including the one shown on the far right there that indicates there may be a modest correlation with sweat chloride, findings that are not consistent with correlations in the earlier data and randomized control trials at the earlier time points at which those have been measured. So it brings to bear, are there aspects of disease state and effects of treatment that may ultimately affect how patients ultimately respond, especially in the long terms? That was part of the question that led to our study objectives. So we sought to estimate the differences in precipitated FEV1 and body mass index pre and post ETI among participants in the PROMISE study. The PROMISE study also has essentially a sub-study which looks at patients baseline ages of 6 to 11 years, and then the adult or core PROMISE study looks at patients above 12 years of age, and was staged obviously with the various times for approval for ETI. And the idea here was to both look at the longitudinal effects and then to assess the effect of prior modulator use, sweat chloride normalization. In other words, those patients that have a sweat chloride that reduces down to the non-diagnostic range for CF versus those that remain elevated above that 30 millimole per liter cutoff on these estimated differences. So just to acquaint everyone that may or may not be familiar with the PROMISE study, like the RECOVER study that Paul spoke about, is an observational prospective cohort study at U.S. centers. It's been sponsored by the CFTR in patients with at least one F508del, and the PROMISE PEDS, the sub-study in those patients that are 6 to 11 years. So this study basically operated by establishing a pre-drug baseline visit, and then patients have been followed. Initially, they're going to be followed for 2 years, and then there was an extension study, which I've been leading for the past 3 years, to look at more long-term and maximal clinical benefits that goes out to, in some patients, as long as almost 5 years. So we will present data on the interim because we have not enrolled any patient out to that full 5-year mark. The nice thing about the PROMISE data is that we are able to also access the USS CFTR, and so we can therefore impute data both pre-ETI to get a longer-term baseline of these kind of trajectories using the USS patient registry, and also impute that data because we're not able to get quarterly visits in the PROMISE study in the research trial setting. So therefore, this data is enriched by patient-reported data, patient registry data from the U.S. as well. So just to get into the endpoints and statistical analysis of this trial, so the endpoints are the pre and post ETI trajectories, which are annualized with 95% confidence intervals for those precipitated FEV1, weight, and BMI. And these we estimated these using assuming of slopes were to be piecewise linear through 3 epochs, which I'll go through in just a moment. So the pre-TI epoch here, that slope on the left-hand side of the graph, is estimated using exclusively patient registry data plus the baseline visit over 30 months from the registry with an annualized slope as described in the graph. The post-ETI change is in 2 parts. One is that initial bump that we see with a lot of patients taking ETI. Many of these patients had that similar type of bump. And then we looked at, after the initial large bump, what happens in the longer term out through, in the case of adults, 48 months or 4 years and 2.5 years in peds. Again, that's due to the offset of approval for peds, so those patients have not been followed as long in the study. However, all will eventually be followed for that to that basically 4.5, 5 year mark in the study. And this was done, and then the estimates were using a mixed effects model, as was described earlier, with slopes, again, assumed to be piecewise linear in each of those epochs throughout. And then we compared the differences in those slopes for some statistical analysis. So and these models were adjusted for age and ETI, so it's essentially controlled for when the patient has initiated ETI in each of the 3 cohorts. So we looked at a cohort that's 6 to 11-year-olds, 12 to 18-year-olds, because that's parsed out in PROMISE, and the over 18-year-olds as adults. And then, of course, stratified for prior modulator status, and then the sweat chloride normalization at the 6-month mark, which is defined as, did your sweat chloride at the 6-month mark, we think you would have had maximal sweat benefit taking the therapy, or estimated to have had that with consistency, be less than 30 versus remain above 30 in the diagnostic range for CF. That was, of course, can be debated, that exact cutoff, but this has helped to produce the analysis rather than having a continuous variable, which could be debated as maybe another way of doing this. So I'm going to go through the demographics quickly, but I'm not going to harp on every aspect of these busy tables. So as you can imagine, there was a large percentage of males versus females. The mean age of initiation was used for the modeling. So the mean age for the PROMISE PEDS participants was about 9 years of age. The adolescent participants was about 15 years of age, and the promised adults was about 30 years of age. So those are the age ranges that were used for modeling the age of initiation of ETI, which, as some may be aware of, may have data that suggests that affects the longitudinal outcomes based on the time of initiation of drug in the natural history of the disease. As expected, most of the patient participants were self-reported white, and about 5 to 7% were self-reported Hispanic ethnicity. There were other ethnicities represented, but they were a lower race and ethnicity category numbers. So about 300 patients participated from the adult cohort, and subsequently we've enrolled about 140 and 150 in the adolescent and peds cohorts. As expected, somewhere around 40% of these patients were on prior modulator based on the fact that this study enrolled patients that were either homozygous or heterozygous for F508del. These are the kind of breakdowns of the genotype groups, and as expected, the adult cohort had a significantly lower percent predicted FEV1 at baseline compared to the peds and adolescent cohorts. About 20 to 30% of patients had a normalization of their sweat chloride in the study, so therefore that cohort is a bit smaller, but it is a significant number of patients that had that normalization. And as expected, the adult cohorts had a significantly higher Pseudomonas rate and were therefore taking more inhaled antibiotics at baseline. We'll get to a little bit of data about self-reported adherence in this study, but not going to harp on it too much, but it's, as another poster we'll talk about in a few moments. So getting down to the data, so the trajectory of lung function and percent FEV1 is similar pre versus post ETI in adolescents and adults. That's what's shown in these cohorts, but interestingly declined in the pediatric patients after initiation of ETI. We don't have exactly an answer for that yet. When we parse out this data a bit and look at forest plots of the responses, we find that in fact that here again, numerically, there's a significant reduction or significant increase in the decline of FEV1 in the pediatric population, whereas before those patients had actually been improving with non-ETI therapy. So as we know, the pediatric population has been showing a lung function increase over time in studies prior to ETI being initiated, maybe because of modulators, maybe because of other care that's being provided. But in fact, that in this study, that did not hold up to be consistent post, unlike what was happening in the adolescents and adults. And that does mirror some smaller observations made from the goal studies in G551D patients made previously by some of us. So thinking about the association with sweat chloride normalization in prior modulators, we began to look at the differences in trajectories based on that stratification. And what you'll see here is that, in fact, the trajectory of sweat is not, though not definitively associated with sweat chloride normalization, but it's numerically better in participants with those that had normal sweat, especially in the pediatric group and the adolescent group. There didn't appear to be as much association with adults with that. There were similar data is not shown here, but did show that there were no significant differences in trajectories observed based on prior modulator status. So this is, I think, is intriguing that perhaps sweat chloride normalization could suggest there's an aspect of improved outcomes longitudinally, and maybe that's why there's part of these correlations that are found more long-term with this. So if this holds up, I think this will be a very intriguing aspect to think about what we should do with sweat chloride as far as a longer-term endpoint, which is, I think, a bit been relegated to not as important given it's this lack of correlation, but I think it's a very interesting concept. So similarly in BMI and weight change here, we're looking at Z-scores. There are similar trajectories pre versus post ETI in adults, and what you can see is that trajectory of increasing BMI, making more of our patients in the overweight and obese range, is held up in this, and the adolescent patients, there was a little bit of a numerical worsening of that BMI trend. Again, not quite sure why that's happening in this population, but it's intriguing that there in fact may be certain populations that don't have the hold up of these trends long-term on ETIs we expected would happen. Perhaps that's good concerning they will not have obesity developing, however it's concerning if they will not maintain the weight they had before. So, and again, looking at the sweat chloride normalization is one potential independent reason for these trajectory differences. We find that in fact, that in general, these trends appear to be independent of sweat chloride normalization, except for the adolescent patients. But it does appear to be a near statistical and certainly numerical difference in those patients that had a normalization of their sweat versus those that remained elevated, as we saw with some of the data previously. I want to call your attention to one aspect. Paul brought up the adherence to therapies, especially baseline therapies and an ETI. Our group has also looked at self-reported usage of baseline therapies as a very likely factor in these kind of findings long-term. This is an alluvial plot on the left, and it showed more simplified, significant declines in self-reported usage of chronic CF therapies. We know there's a relative paucity of data on what the long-term effects of withdrawal of therapies are. The Simplify study told us a lot about short-term, but the long-term effects are not known yet. And so I guess I'll use this data as a little bit of a cautionary tale that our patients are telling us they're not doing as much of their chronic therapies, and we don't know what the effect will be long-term. So not to say it's a danger, but not to say it's totally safe for our patients. I would invite you, if you're interested in this work, to see the rest of the story that Scott Sagal will be presenting in a poster 831. So I'm going to conclude here by saying that despite prior clinical trial data demonstrating persistent elevations in weight and pulmonary function trajectories, our data shows there are some differences in those post-ETI, especially in children and adolescents. The trajectories of the BMI and weight changes are similar pre versus post in adults and young children, but interestingly lower in the adolescent population with an unclear reason. This data is largely confirmatory of what's been presented from the GOLD study and a smaller analysis done a couple of years ago by our group. The sweat chloride normalization may be related to the improved trajectory of lung function with some numerical differences. We can't make a firm statistical association of this, so I think more work will have to be done to answer this, but I think it's intriguing that there may be something to the concept of normalizing sweat chloride with additional medications in the future. There's obviously a lot of limitations to this data. We weren't able to fully control for adherence to both ETI or chronic therapies. You can see that obviously was a moving baseline throughout the study, just based on the other data being analyzed for this conference. And we are analyzing that association. Furthermore, we acknowledge there may be some limitations to to PFT performance in younger children. So we're hoping to deal with that as we go along with the study. So if that, I'll just say we're having ongoing data analysis and collection to confirm these findings and more in longer longitudinal data from the PROMISE PEDS and PROMISE core adult study. And so we really thank you for your attention. I'm happy to take any questions you may have. I want to, sorry. Got ahead of myself. I really need to acknowledge that the people with CF and their families who participate in the study, the site PIs and the RCs and all the studies. This is a massive study that's been ongoing for years in the U.S. And I really have to thank the TDNCC stats team who helped me tremendously in some statistical analysis that is way above my pay grade. So I really appreciate their help, all of them at TDNCC. So thank you again. I'm happy to take any questions.
All right, we have one online question here. They say old data from the ECFS indicate that those at highest risk of FEV1 decline are those who start with the highest FEV1. Might this explain the increased rate of decline in the youngest cohort?
Yeah, and that is shown in our data, and it's been shown in the GOLD, the smaller GOLD data as well. So I think it suggests either that there's something different about what happens with patients that have higher lung function, maybe they have less symptoms, they never develop. Do they have a change of adherence? They never initiate some of their therapies, or there's something else uniquely different. We can't piece out there's a significant other demographic difference, nor is there more sweat chloride normalization necessarily in these patients. So I can't fully answer that, but I think this has been found in a couple of other studies now, and so there's probably something to say for that. That said, that population has a lot larger buffer, so that more rapid decline may not be as clinically apparent in those patients, certainly in the first years after initiating therapy. Now, will it have an effect as you go out 20 and 30 and 40 years? No way to answer that, but I think it's a very intriguing finding, and it's a well put point that has been pointed out in some other publications as well. So if this holds up, it'll be confirmatory in a larger data set.
Thanks so much for this talk. I think it underscores the importance of real-world evidence. The thing that strikes me is how different these data are from the Vertex OLE studies.
Yep.
Could you hypothesize wildly a little bit about why you see that difference? I mean, there's obviously the observer effect of being on a trial, but is there a population difference? What do you think is going on?
I think there's a number. I'll repeat it a second. The question was, can we hypothesize a bit about why this data and in general the real world data looks so much different than the open label extension? Others can feel free to comment on this as well, but there's a few factors. One is, as you mentioned, the concept of you're in a trial, you're a bit under the microscope being in a trial, right? The trial participants for the Vertex open label extension studies had to have fully completed and remained, at least from the PI and study teams, very adherent to their treatment throughout 48 weeks to be able to roll into that. So that in of itself suggest that there's a highly adherent population. This real-world data doesn't dispel that. The open label extension had the same, if you go to the background of it, you had to have been eligible for the initial randomized trial, which means you had to have a higher lung function at baseline, at least above 40, right? So you had to kind of be in that sweet spot for modulator studies, that 40 to 90 for adults, a little bit larger range for kids. So therefore, the severe lung disease patients, which we have a number of those here in this study, and the real world studies are not, as inclined to exclude from enrollment. There's that aspect of it too. Now, whether or not that means they're going to decline more or not, but I think it just makes the populations different. I don't think there's a significant number of demographic differences that would dispel that, but could there be differences in patients that are willing to participate in trials, having slightly different socioeconomic, other backgrounds we just can't account for? So I think there are a number of factors, not to mention that we think there's a generally higher adherence of patients that are willing to participate in long-term trials, probably on all their therapies, and the Vertex trials request the patients continue adherence to their background therapies throughout. Now, I'm sure whether or not they did or not, I can't say that. But probably the self-reported adherence would be higher than this sort of real heavy decline we see. That's why I presented the data that's going to be a poster from Scott, because obviously there's a pretty heavy decline there, as Paul was just mentioning, to even with the ETI, right? So I think all those factors at least play some role. But Jen's a huge expert. I mean, she can come with that before she asks her question.
Yeah, no, I think the populations are so different in real world studies and in trials. Which is why I said to Paul in Glasgow, thank you for his huge effort in these real world studies and yours as well, because we can't just rely on people who are in those studies because it's very different. Obviously, even if you just look at the racial demographics of people who are in those studies versus what's actually happening in the real world, very different.
Yeah, I think we had a certainly higher Hispanic ethnicity population in PROMISE than was observed in the Vertex studies. It was a much more self-reported non-Hispanic white population. Even that was a general demographic was similar, but I think there's that one factor. So
again, thank you very much. And sorry if I missed this, but obviously there's a huge sex gap in CF that hasn't been resolved since we started introducing modulators as shown by Raksha and others. Did you look at the sex differences based on pre-puberty versus post-puberty, especially in that adolescent period?
In the analysis it came up. It's a great question. We've not been able to get to that, and there's a plan and other analysis to look at that question separate from this. This was really born out of the concept of the sweat chloride normalization, so we try to keep the larger population to build enriched for sweat chloride normalization. It's a great point, and we're going to be looking at that as separate, and it may be a contributory analysis of this. So great point. We haven't done it yet, no. Thank you all.
Thanks, William. All right. I'd like to welcome Dr. Paul McAnally back to the stage for his second talk of the workshop. He'll be speaking about liver disease outcomes in people with CF after 2 years of elexacaftor, tezacaftor, ivacaftor results from the RECOVER trial.
So again, this data, Emer Fitzpatrick, our hepatologist, was going to present this data, but couldn't unfortunately make it, so you're stuck with me again. So thanks a million to the organisers for inviting our two talks in this session. So I'm going to talk now about liver disease outcomes in people with CF and what we discovered as part of the RECOVER study. So here are my disclosures. It's always very difficult when pulmonologists look after people with a multisystem disease. We tend to concentrate more on the lungs. We know more about the lungs, and we all like doing things we know about. And we sometimes neglect things we don't know a lot about. So we really rely on our hepatology colleagues. There has been a lot of confusion over the years about CF liver disease, what it is, what are the components, who has it, who doesn't have it. And this has driven the community, and particularly in these two really important recent publications, to be much more clear about defining CF liver disease. And so our understanding is evolving. It's definitely it's a very heterogeneous entity. Even in the last couple of years, the whole understanding about the vascular nature of it, as opposed to the obstructive CFTR-based fluid shift hypothesis from before, that things are still changing. So these papers have helped us to have a bit clearer classification about what CF liver disease is. And so it's got a couple of different components. Obviously, the liver function tests that we all do every year, and we've heard about this with modulators. Ultrasound imaging, measures of liver stiffness, and then signs of cirrhotic or non-cirrhotic portal hypertension. So there's a couple of different, previously a couple of different stabs at classification, and the one that we had used in the Irish longitudinal study was people who with no liver disease, with non-specific liver disease, and then with advanced or proper CF liver disease. And these recent position papers have taken a reasonably similar track, but the terminology is modernized a little bit. So we've got CF no HBI. So this is, hepatobiliary involvement, or HBI, comprises ultrasound abnormalities. Sorry, I don't know why that changed. Ultrasound abnormalities, abnormal liver function tests, and signs of liver stiffness or portal hypertension. And then CF-HBI, and then advanced CF-HBI. So advanced CF-HBI is our good old-fashioned advanced liver disease with cirrhotic or non-cirrhotic portal hypertension. So we've got these three categories, and within that non-specific or CF-HBI group, that's a heterogeneous group as well. But for the purposes of understanding it, it's important to look at these three areas. So what don't we know, or as I should probably clarify a little bit, what didn't we know before yesterday when Michael Narkovich presented the PROMISE data? So what we didn't know before yesterday was, do modulators adversely affect liver enzymes measured in the real world? Obviously, we know of the trial data. Do they improve markers of liver fibrosis? And do they reduce the likelihood of progression of liver disease? Because we know from the Irish longitudinal data that liver disease can progress. And so that's one of the key things, especially as a pediatrician, that I'm interested in. So again, I've shown you this before, the RECOVER studies of 8 sites in the UK and Ireland. And we're looking at a lot of pulmonary and non-pulmonary outcome measures. So the two key ones I'm going to talk about today are liver blood tests, and these were done annually, and liver ultrasound examination as well, and they were done annually. So we used the laboratory analysis in the first year of treatment on ETI, certainly in Ireland, and I think in the UK as well. We were mandated to perform labs 3 monthly. So I'm not including that data. I'm just looking at the annual data, which reflects clinical care. We'll talk about that elsewhere. We didn't perform liver stiffness measures. Our group had previously looked at this and found it to be highly variable within the healthy populations to the point where we didn't think it was reliable to use as an outcome measure in this study. And then ultrasound. So we had a scoring sheet. Obviously, we didn't centralize the image collection or analysis because it was in 8 different sites. But we had a worksheet, and we had increased echogenicity or normal echogenicity, heterogeneous, homogeneous, and nodules. So we had a reasonably kind of tight view on that. We didn't centralize the review of images. So just looking at our study population, so RECOVER, obviously, like Marty was talking about, there's 2 phases, the 12 and overs, and then the 6 to 11s based on drug prescription. So we haven't completed the data collection in our 6 to 11 cohort yet. So this is just the data from people 12 years and older. And so this was a younger cohort, a high proportion of adolescents. And you can see lung function, baseline lung function prior to ETI initiation at a reasonably decent level. And again, the pre-treatment sweat chloride 85. And most of the cohort here, 67%, were homozygotes for F508del. So at baseline, we only had 5 people with advanced CF liver disease, and like the data that Michael presented yesterday, they only had 12 patients in the PROMISE study. So they're small numbers in the advanced category, and then roughly a 50-50 split between those with no liver disease, and those with CF-HBI. So there were 9 withdrawals due to adverse events in our study. Only 2 of these were related to liver enzymes. So not much of a fall off in terms of withdrawals, but we do have some missing data that I'll show you. So the first, so this is a Sankey plot, which, yeah, you've seen these, and Marty showed some of these. It just shows the numbers at different time points, and it visualizes the change. So these aren't flow of individual people. This is just group change over time. And the orange you'll see here is data that was missing. So if somebody didn't have a liver function test, or if they didn't have an ultrasound performed. So you can see, so this is any liver disease. So this is advanced HBI or CFHBI, and it excludes people with no liver disease at all. Sorry, any liver disease is the yes, and no liver disease at all is the no. And so you can see there's a few people moving to the, sorry, I don't know why my slides keep jumping ahead. There's a few people moving around, especially down to the missing data, but largely over time, if you have liver disease, you still have liver disease. If you don't have liver disease, you remain without liver disease. When we look at those classified as CFHBI then, again, we're seeing something similar. There are some changes in classification over time, and this is mostly due to liver function tests. We've got some missing data, but overall the numbers are pretty static if we account for the missing data. And the same with advanced CFHBI, with those 5 participants all the way through. And those without CFHBI, again, accounted for the missing data that we saw. So thinking about what we would expect over this 2-year time period in 115 participants. So just looking back at the data from the Irish longitudinal study as a 10-year window between 07 and 17, 13.6% of the people with non-specific or HBI ended up with liver disease, and 4% of the ones with no liver disease ended up with advanced CF liver disease. So not a huge, and that's over a 10-year period. So we wouldn't expect to see much movement in 5 individuals with CFLD. So even if we did see some movement, it's probably out with the realms of statistical power. So when we look at, so this is extremely messy, so apologies for that. When we look at, on the left-hand side here, the changes in ultrasound appearance over time, so we've got the increased, homogeneous increased echogenicity, patchy or nodular increased echogenicity, or just heterogeneous without increased echogenicity. Or elevated liver function tests. Again, this is real-world clinical data. There's movement between some of these categories, but overall, accounting for the missing data, you can see there's not much change over time. And the same with spleen size above the upper limit of normal, accounting for, because that's a binary cutoff, accounting for that on the missing data. Again, we really didn't see much difference in our data. So then when we look at abnormal liver enzymes, so I'll just acclimatize you to this figure. So because we had missing data at different time points, we used percentage, so the percentage of individuals who had abnormalities. And so if we look at ALT just, the ALT greater than 5 times the upper limit of normal includes everybody above 3, above 2, and above 1. So these are not distinct groups. These are, as you go up, they include the numbers of individuals from the previous groups. So we just looked at this across all the different liver function tests and across, from baseline to 1 year to 2 years. Now we haven't, again, we only have really produced this data in the last 2 weeks or so we haven't analyzed this statistically. And again, there's limited rationale probably for doing that based on the data collection time points and the meaningfulness of the data. But you can see there isn't much difference between any of these categories, any of the liver function tests over time. And then you can see if we just pick ALT and we just look at the Sankey plots, we've got no abnormality down the bottom and greater than 1 times upper limit of normal. You can see there's huge movement between these two and missing data. So it's a very messy system overall, but I think we can say that there isn't a huge amount of change in liver function tests over the course of 24 months. And this really reflects what a lot of other people have found in the real world. So let me turn and look at these liver fibrosis indices that have been published more recently as predictors and having the ability to track changes over time and identify people at risk of developing liver disease. So the first one of these is APRI, and you can see there how we calculate APRI. And not surprisingly, really over this short course, we didn't see any change in APRI in those with no HBI, with HBI, or advanced HBI. Obviously, the numbers are small, and as expected, and it's reassuring in a way that we're seeing very abnormal numbers in the advanced liver disease group, but these haven't changed over time, albeit that we've only 5 participants in this group, and again, Michael showed similar data yesterday with only 12 participants. So we're seeing something very similar for FIB4, which uses AST, ALT, and platelets. No statistically significant changes over time in the advanced group with much higher markers, and the same for GPR, which has found to be a little bit more sensitive to changes in liver disease and CF over time, but in our cohort we didn't see any differences. So overall, in conclusion, it's a complex and messy area. There's some things in medicine that are simple and linear and binary, and this is not one of them. This is one of the messy, complicated, nuanced things. So if you're looking for a simple answer, you're not going to get it. There's no obvious evidence that ETI causes significant liver injury or decompensation in people with advanced liver disease. It's too early, though, and we don't think either that it's associated with improvements in liver status or liver fibrosis or risk for fibrosis in the data that we've seen so far. But it's too early to establish if we have reduced the incidence of serious disease. And what we need for this is much bigger numbers, longer follow-up, and pooling of data sets. And I think it's going to be very important for us and the PROMISE team and other real-world groups to put our data together and to look at, combining it with registry data. In particular, the first decade is the important time for the development of CF liver disease, so we really need to look very carefully in that. And again, our study and our study called ENHANCE, which is our newer study in younger children, and the BEGIN study in North America will enable us to collect that type of important risk-based data to see if we can, if ETI or the newer modulators can prevent the development of advanced liver disease. So again, I won't repeat all my thanks because you've all heard it before, but thank you to all our wonderful staff, all the participants, and our funders. I'm happy to take questions.
I'll start off the question. Thanks, Paul. That was a great talk. How do you think your results would impact recommendations for following adults on ETI after the first year? Do you think that there should be a change in how they're monitored, like if they're on ETI versus not?
Sorry, I missed the first bit of that.
Beyond the first year on ETI, based on your results, do you think that patients on ETI should be followed more closely than the current recommendations with regards to their liver indices?
Are you talking about measuring liver enzymes and that type of thing?
Yeah, imaging and FibroScans.
So this data and the PROMISE data and other real-world data has really shown that at the frequency that we measure them, there's no detectable liver injury or hepatocellular injury with ETI that we need to be paying more attention to. We didn't present the data, but we looked at every 3 months for the first year, and again, we didn't see anything very significant. So I think the data suggests to us that we need to, back off on the frequent, regular testing. I think, we have a population that uses a lot of medicine, and everyone gets, infection, and we use antibiotics and that. So you're going to see fluctuations in liver enzymes, and we actually don't know in healthy people who get, viral infections and take medications. We don't know what that natural history is. So I think we've sufficient data here to enable us to take the foot off the pedal a little bit and don't overdo it with checking liver enzymes because, first do no harm.
We have new liver guidelines as of the past year. I think you showed that on your first couple of slides, and the recommendations are for instituting sort of routine imaging into practice. I don't know how many programs are doing that. And show of hands for programs that have implemented routine imaging. We've kind of struggled just because of the number of things that patients are asked to do, and it's like one more thing on the checklist. But yeah, so we're working on it.
I think some of the natural history data shows that there increasingly you can isolate the people who are going to develop more advanced liver disease. The problem is, you know, it's like newborn screening. If you can screen for something but you can't treat it, you might be doing more harm than good. So at the moment, unfortunately, we don't have a, you know, outside of hopefully modulators, we don't have a good treatment for people who develop the type of advanced CFHBI.
There's a comment about liver disease being more of a vasculopathy as opposed to sort of a biliary disease with a channelopathy.
And that would make a lot of sense in terms of the data because, I mean, if it was a fluid shift kind of a chloride pump or chloride transport issue, you should see, like pancreatic disease, some immediate signal. And we're really not. And the data basically shows us that there's no change. So you've got some kind of injury that's there, and you know we haven't been able to reverse that injury. But the question is, can we prevent it? And so, if it is a kind of vasculopathy, which Michael Markovic in his talk yesterday, you know, he really feels, and he's obviously a leading expert in CF liver disease, really feels that the vasculopathy that this is more like a vasculopathy than anything else, and that would fit with this data that we're not showing that immediate difference. But the hope would be if you can prevent the upstream abnormalities, that we'd be able to prevent that.
We have Dr. Alfonso Galdarisi from Paris, who will speak on triple CFTR modulator combination improves glucose tolerance in adolescents with CF.
Thank you. Thank you for the invite. Absolutely not. It's a bit confounding there. I'll share with you the data from the French National Registry of people with cystic fibrosis. And I'll try to shift your attention on another extra pulmonary complication of CF, CFRD, so the diabetes associated with cystic fibrosis. First of all, a little background, as usual. Cystic fibrosis, diabetes, and all the spectrum of glucose tolerance impairment we observe in adolescents and then in adults with CF are driven by multiple factors. There is a primary defect in beta cell function that has been well described by many groups. There is also a reduction of insulin sensitivity, and more recently some authors from a from a German study described an increase of insulin clearance. That means your liver is basically getting rid of more insulin, so there is much less insulin peripherally to do the job. And there is a doubtful role of the incretins, I mean the hormones produced by the gut, so GLP-1 or GIP, in adolescents and adults with cystic fibrosis. But these are the mechanisms underlying diabetes. Then diabetes itself acts as an aggravating factor for all the other comorbidities associated with cystic fibrosis. So we know that a person with impaired glucose tolerance or CFRD will have more frequent hospitalization, will have more frequent infections, and overall the outcome of this person will be worse by the existence of CFRD. So it's a sort of amplifying factor, not just a complication. And certainly for the family, my key disclosure is I'm a pediatric endocrinologist. So I saw that for a family discussing the opportunity of treating diabetes in a pretty complicated disease is by itself a big burden. They have a lot already on their plate, as you guys know. We started having great expectations on the effect of CFTR modulators, including the triple modulator, on different comorbidities. In this session, we have spoken of liver, we spoke of BMI changes, and we tend to be pretty optimistic about the effect of CFTR modulator on all of them. What impressed me, again, as a sort of outlier to your community, because I did endocrinology, eyes. Today with this drug, we can project and discuss with the families the fact that we are giving them more years to live. That is not a trivial achievement for a drug. What we are trying to answer is, how does your life look like if we increase it, we extend it? So the sense of this talk goes exactly in this direction. Can we say that these extra 20 or 30 years we have been gifted by the drug will be diabetes-free years? There are already several small cohorts from the US and from Europe that describe the potential effect of triple modulators on beta cell function itself, with apparently an increase of insulin secretion, but then controversially, and that sounds quite awkward, a reduction of insulin sensitivity, but indeed this is what has been shown by some authors. And overall, the effect of the treatment on glucose tolerance remains pretty questionable. That means we do not know. We have cohorts of 20 to 30 kids or young adults, and we do not have final results. We cannot close the story. So with this study, we tried to answer the question if the treatment with CFTR modulator, the triple modulator, impact 2-hour glucose in youths with cystic fibrosis. To answer this question, we used the French National Registry module CF that includes all the kids who are eligible for treatment with ETI or with other CFTR modulators. The registry counts on more than 800 kids, most of them younger than 11 years old. This is the population. And each site, all over the country, including the highlands, basically, was offered to perform an OGTT before the beginning of ETI, 6 and 12 months later, and along with the clinical monitoring, the auxological monitoring, and certainly the lung function monitoring. This is a real-world registry. This is not a clinical trial. Therefore, each site was also allowed to refuse or not one of these tests. For this particular analysis, we included all the people carrying the F508 deletion who were eligible for treatment with ETI in the age range 12 to 18 years old and who were not using insulin. This is an important point. We included people with a diagnosis of CFRD only if they were not using insulin, who were started clearly on ETI. The treatment with a prior CFTR modulator was not an exclusion criterion for this analysis, and our primary outcome was 2-hour glucose. We evaluated the participants before the treatment and 12 months after the ETI treatment. The analysis has been stratified according to the baseline glucose tolerance. So we included people with normal glucose tolerance, and in this bucket we also put those with undetermined glucose tolerance. That means if any time point during the oral glucose tolerance test was above 11.1 millimole or 200 milligram deciliter for those ones using milligram deciliter, without meeting the criteria for impaired glucose tolerance or IFG, these people were classified as having normal glucose tolerance and altered glucose tolerance. In this bucket, we included people with impaired fasting glucose or impaired glucose tolerance. We analyzed data from 106 participants. These two groups, a baseline, that means before being started on ETI, were similar with respect to age, sex, and also with respect to the use of a prior CFTR modulator. More or less half of this cohort was on lumacaftor, ivacaftor, combined treatment, or ivacaftor alone. The only differences between these two groups were clearly in 2-hour glucose and 1-hour glucose, but we do expect it as study design. What happens 12 months after ETI treatment. For those with a baseline normal glucose tolerance, you can see in blue the glucose profile during the OGTT before the treatment, and in red after the treatment. There was actually no difference in 2-hour glucose, as well as no difference in the 1-hour glucose. While for the group with baseline altered glucose tolerance, we observed a reduction in 2-hour glucose. As you can see, the red square here is the 12-month 2-hour glucose during the OGTT. Here you have the actual data. Basically, this observation allowed us to say that the treatment was associated to a lower 2-hour glucose 12 months later. Again, this is an observational study, so we cannot say that the treatment caused it, but certainly the longitudinal trajectory was suggestive. With respect to the other outcomes, in our cohort, even though we didn't do the slope analysis that I found pretty interesting before, the raw data of BMI displayed an increase of BMI zeta score 12 months later, as well as an increase of the FEV1 and a reduction of the sweet chloride. And this is one last point. When we discuss beta cell function, glucose tolerance, and 2-hour glucose, sometimes we believe we are speaking of the same thing. But for real, the results can be discordant. So we wanted also to offer you a different way of looking at things. This is the same cohort classified by glucose tolerance. In green, you can see the people with normal glucose tolerance at baseline, 75. And as you can see, the majority of them, so more than 80%, stayed with NGT. About 20% progressed to indeterminate glucose or impaired glucose tolerance. Here you can see on the left column also the indeterminate glucose tolerance group. They basically went all over the place, if we want to say this in a simplified way. Lastly, those with impaired glucose tolerance at baseline, at least 50% of them returned to normal glucose tolerance, and the other ones stayed in the impaired glucose tolerance group. We only included 3 people with CFRD at baseline, as I said, not treated with insulin, and they all returned to impaired glucose tolerance. So the last thing is we tried using a 3-point OGTT, so an OGTT with 0, 60 minutes, and 120 minutes time point, to see if any of these points would have been a good predictor of glucose tolerance at 1 year. And apparently, using a threshold of 156 milligram deciliter that correspond to 8.7 millimole, we had 80% sensitivity to identify those who would have returned to normal glucose tolerance. This threshold has been described by other groups as associated with a reduction of insulin secretion. Why we did this kind of analysis? Because the 1-hour glucose time point is not standard of care, is not part of many screening programs, at least in Europe. So this was a way to ask ourselves, should we add another time point to the OGTT? So to summarize, we observed certainly an improvement in the respiratory function, an increase of BMI after 12 months, and a reduction of 2-hour glucose. We also observed apparently an improvement in glucose tolerance. Still, this study, as I said, is an observational study. This is a peripubertal cohort, so we do not have we cannot say how much puberty played and the pubertal transition played in the results we observed. And the major limit of these studies will lack of accurate measure of insulin secretion and sensitivity. I showed you only glucose measures, but not insulin or C-peptide measures. The good part of the story, I would say, is this is a cohort representative of France. All the people had access to the medication. We do not have data on compliance. I found the previous presentation pretty interesting. And the last good point is we also can see a parallel trend between the metabolic data, the BMI, the zeta score, and the respiratory data. And that's pretty much all. I'm open for questions. And certainly, I'm happy to report data collected by the entire country. So I have to say thank you to all the investigators, obviously. Isabel Sermebus is the person who coordinated this big national job, and all the families who came in for an OGTT as an addendum to their routine. Thank you.
Do you know if anybody's looked at insulin levels or C-peptide release with the glucose tolerance test?
We did not. That's, I believe, the measure limit. We had data on insulin and CPAP from other courts, from Colorado and from Germany. And insulin secretion apparently is improved by the use of the treatment, but again, it's from small cohorts.
I have a question. Thank you for your talk. That was an excellent talk. Thank you. Do you think that there's a role in incorporating like a 1 hour glucose tolerance test routinely in screening for CF-related diabetes or impaired glucose tolerance?
There's a mechanistic explanation for those findings. I mean, this is not the first study showing that 1 hour glucose can be more predictive than 2 hour glucose, mostly because 1 hour glucose somehow reflects the beginning of insulin secretion. Insulin secretion is sort of bimodal, and 1 hour glucose is a sort of cheap measure for this biphasic secretion.
I think a lot of our patients would prefer to have a 1 hour instead of 2 hour also. So
yes.
Thank you.
Right, I'd like to welcome our final speaker up to the stage. Dr. Raksha Jain is a professor of pulmonary and critical care medicine at the University of Texas Southwestern Medical Center in Dallas. She will be speaking to us today about maternal and fetal outcomes in the era of CFTR modulators, interim results from the Mayflower study.
All right, thank you, Sid and Allison, for the opportunity to speak today. All right, and I want to acknowledge my co-investigator on this study, Dr. Jennifer Taylor-Kauser, as well as her excellent entire Mayflower study team, who all participated in years of work in collecting these, designing the study, enrolling patients, and to all of you who might also be participating in the study. We appreciate your efforts. These are my disclosures. So just to give you a brief background, I think some of you may have seen these data already, that based on the US CF Foundation registry data, excuse me, we have seen a dramatic increase in pregnancies since the widespread availability of ETI. And much of the data we had on pregnancies, or that we've been quoting, is really data collected prior to the use of modulators. And as we've seen this increase in pregnancies, we know that people with CF and their families have a number of questions about the implications on their health as well as their infant's health. And so this study is really designed to help provide some data to answer some of those questions. Just to give you a little background on the aims of the study, the primary aim is to assess whether changes in lung function, or assess changes in lung function during pregnancy and after, based on modulator use, but also in relationship to other factors, including demographics, et cetera. Secondary aims include describing pregnancy-related and obstetrical complications, as well as changes in mental health. And there are some exploratory aims, including sub-studies, which are going to evaluate CFTR modulator pharmacokinetics and glucose control surrounding pregnancy, which Dr. Melissa Putnam is leading, as well as infant outcomes and developmental milestones. Just to walk you through a little bit of the design of this study, this is really the first prospective study of pregnancy that is being done in CF. It includes 40 sites. It's an observational study, so we are not at all involved in the decisions made by the participant or the clinicians in their care during this study. And it includes anyone who's with CF greater than or equal to 16 years of age, currently pregnant, and importantly, planning to continue their pregnancy. They can enroll at any point during their pregnancy in the first, second, or third trimester. We capture data including lung function, different questionnaires, a blood draw for banking, et cetera. Capture data at the time of their delivery, and then capture information at every 3 months in the first year, as well as every 6 months in the subsequent second year. So here's where we are with data thus far, and this is as of August 1st of this year. We've enrolled 279 participants with a goal of 310 participants, including early withdrawals. So we're close. We have not yet completed enrollment, but we hope to ideally by the end of the year. And when you look at the distribution around the United States, it's fairly well distributed, though it may look like Texas is providing fertility potion in the water. This is actually very in line with what is out there for the general population. And then when it comes to our glucose control monitoring sub-study, this is being led by Dr. Melissa Putnam, as I mentioned, and we have 59 participants in this thus far. She's going to be mentioning this a little bit in her diabetes plenary this evening, so I encourage you to attend that. But I think very importantly, what I did want to point out is this glucose monitoring study is actually not just going to include females with diabetes, but also those with impaired glucose tolerance and those with without impaired glucose tolerance or diabetes, so there can really be a wide spectrum of data available on understanding glucose control in pregnancy. And then there's an ETI pharmacokinetic sub-study, as I mentioned, where we currently have 31 mother-baby participants, and this is set up where we're going to be collecting data at the time of delivery, obtaining maternal blood, cord blood, infant blood, as well as subsequent visits where we collect breast milk and infant blood and mother blood as well. So I think this will help us answer a lot of questions in the future, but we do not yet have that data available. So just to give you a little bit about what we do have in terms of characteristics, et cetera, and very importantly, I want to acknowledge that we have not statistically analyzed this data yet, but in our 279 participants, the median age we have is 30, but there's a wide spectrum down to age 17 all the way up to 41. So this will really allow us to ideally take a look closely at age and how this impacts pregnancy as well. The large majority of the population is white, 95%. There's 6% people who identify as Hispanic. The distribution in genotype is probably as predicted. Importantly, there are 36% of participants that do have diabetes. And when you look at the median BMI pre-pregnancy or at baseline, it's 23, so a fairly good BMI entering the study, and the median FEV1 at baseline, 83. But again, a wide spectrum down to 25% all the way up to 123%. So again, a terrific opportunity to look at whether baseline lung function may impact some of the outcomes we see. Then when you look at fertility assistance used in this population, thus far in our participants, we see that 12% used fertility assistance, and we plan to take a deeper dive into what those are, as well as the circumstances. Of the data we have on partner testing, you can see that 16 people, or 6%, had a father who was known to be a CF carrier. 69% where the father was not found to be a carrier at all, and 25% where we don't know that information. Of these, we do know that there are 2 babies that have been born with CF within our cohort, and we do plan to take a deeper dive into that information. And in terms of previous pregnancies, I think the important thing to look at here is about 60% of the population had a previous pregnancy, including 45% who had a live birth in the past. So that'll also lend itself to the opportunity to look at the impact of having your first child versus your second child or further on the outcomes that we see. Then you look a little bit at modulator use. And maybe this is not quite a surprise, I think, in our current era, but you can see that really over 85% of the population used modulators continuously throughout their pregnancy. And when you look at what those modulators are, 82% used ETI, 2% IVA, and 2% TES-IVA. There was nobody in our study thus far who's used LUM-IVA. When you look at the non-continuous use, meaning they started or stopped some point throughout their pregnancy, that's 7%. And when you look at people who use no modulators, that's also 7%. And breaking down those 16 participants who use no modulators, of those, 10 of them did have genotypes that were that they were able to use modulators but chose not to. So this is just a spread of the lung function, and though it's quite busy, again, we have not statistically analyzed or included any of the adjustments that we'd like to do long-term. And importantly, when you look at this includes their pre-pregnancy FEV1 over on the left-hand side, their 3 trimesters of data we have for their lung function throughout their pregnancy, and then their subsequent lung function after that. And the numbers decrease over time in terms of our N, and that's largely because there's many people still in this study whose data we're collecting. So we don't yet have the full spectrum to give you an analysis, but I think when you just hone in on the mean FEV1 down at the bottom, so far I would say that there's no obvious trend of concern, which is good news, but again, we have to take a deeper dive into this. Similarly, I just wanted to share the information we do have on weight thus far. And, I'd say again, taking a bird's eye view of this, it looks potentially as would be expected, where people are gaining weight during their pregnancy, peaking at the 3rd trimester and coming down into levels that, at least per this data, look like they're matching where they are about in first pregnancy. But, again, we have to look at this in detail, but just wanted to share that thus far, that's looking not too concerning, which we're glad to see. Other information that I think is really unique to this study, and we're happy to have, but we'll be looking at this further as well, is PHQ information, which is a measure of depression. And you just look across the board on this throughout our population. And the really good news is when you look at the means, the mean throughout is really somewhere between 3 to 4, which shows that there's no significant depressive symptoms, which we were pleased to see. And you further look at the GAD questionnaire, which is a measure of anxiety. And similarly here, you can see that the scores across the board are somewhere between 3 and 4, which indicate minimal anxiety. So good news overall. But, there are people, obviously, you can see that are out there as outliers that we need to understand better. So then taking a little bit of a look into the infant outcomes. So overall, we have information on 239 outcomes of delivery thus far. And in those 239, there was 95% live births. That's 226 babies. The median gestational age in the population thus far is 38 weeks, with a range from 27 to 42 weeks. There is 22% of the babies that were reported to be premature thus far. That means they were born at less than 37 weeks. In terms of pregnancy losses, we do see that at 3%, which is actually a little bit lower than the general population. And when you looked at induced abortions, it's 2%. Then just looking at the modalities of delivery, in terms of vaginal deliveries, we see that in those 226, 47% were born through vaginal deliveries, 39% through C-sections, with there being more in the low transverse C-section group than the classic C-section group. And that is a little bit higher than what we see in the general population. 1% through forceps delivery, and we do have about 13% where we're missing data right now. Then taking a look at delivery complications, which you see on this next slide. The top really is participants who had more than one or more delivery complications. And this is 53%. And I'm just showing you a subset of this data. We actually have a lot of granular data, but we broke this down into delivery complications occurring in greater than 10% of cases, and that was just gestational diabetes, which you can see here at 18%, which is a little bit greater than what we see in the general population, and delivery complications occurring in 5 to 10% of cases, where you can see that we saw abnormality in the placenta in 6% of cases, use of betamethasone for preterm labor in 6% of the cases, gestational hypertension at 6%, which is actually pretty similar to the general population, group B strep in 10%, and preeclampsia in 7%. We also took a look at some of the infant complications, particularly in the first 6 weeks post-delivery, and you can see that we had 55% of the infants that had at least one complication in those first 6 weeks. Of those that had of those complications that were occurring in greater than 10% of the cases, 20% of the infants born did have extended hospitalizations. 20% did have an extended hospitalization involving a NICU admission. 22% with preterm births. and 18% with respiratory disorders. And that preterm birth is a little bit more, again, than the general population. When we look at infant complications occurring more in the 5 to 10% of cases range, you can see that we saw 7% with a type of non-cardiac congenital defect, 10% with a feeding or weight problem, 8% with hyperbilirubinemia, and 6% with hypoglycemia, 14% with jaundice. Then just taking a little bit of a look at the babies, and overall, this is data obtained at the time of their birth, that the APGAR scores at 5 minutes, the median was 9, which is actually a normal range, which is good. Median weight, 3.2 kilograms, which fortunately is also an appropriate weight. Length of 50 centimeters, also appropriate, and occipital head circumference of 34. So the good news on this data so far is it's looking like much of this is in line with what we normal ranges for newborns when it comes to the medians. And then we also have data on infant milestones. And again, I think these are some of the uniquely wonderful opportunities the Mayflower study has lent itself to. But this is where we're actually capturing data on whether the children born to these moms are meeting their developmental milestones at 3, 6, 9 months, et cetera, following them up to 24 months. And you can see overall that, that the way we've reported this is the top line is the mean milestone percentage. And then we have those that met 50, 75, and 100% milestones across. And overall, I would say that this looks good. We did also, well, at least in terms of this data, if we did not receive information from that participant, it was assumed the baby did not meet the milestone. So these numbers may actually look a little bit lower than they are, but we did, I think that's an important point just to note. But either way, when you look across this, the majority of babies are reaching their milestones. And actually, when you look at the mean at 24 months of 94%, again, I think that's quite reassuring thus far. But keep in mind that at 24 months, we only have 24 babies reported right now. So we have a lot more to learn as we get the rest of the data. So just preliminarily, our enrollment is nearly complete. We hope by next year's NACFC we'll have completed enrollment, be able to share with you the final statistical analysis. The majority is what we're seeing so far. The majority of participants are choosing to continue on their CFTR modulators for all of or part of their pregnancy. And I think this will really allow us to have new modern data to provide to people we care for. Pregnancy losses are occurring in less than 5%, which is actually less than the general population. But keep in mind, one of the criteria of this study was that people were planning to continue their pregnancy. So we may have a slightly biased population relative to the general population reports. And then approximately 40% of the births were delivered by C-section and 22% were premature, which is a little bit higher than the general population, but we can't make firm conclusions about that until we really take a deep dive into the statistics. So with that, I'd really like to thank the participants and their families. This is a lot to ask of them, particularly when it comes to capturing their baby's data, and for those in particular who allowed us to draw blood on their baby, as well as all the centers who've been amazing in helping us recruit, and to the Mayflower study team who's been terrific. So thank you all, and I'm happy to answer any questions.
Hello, hi. Congratulations. I know how much you worked on this for the last 5 years, and it's amazing to see the interim data. I'm Sheila Modi, I'm an OBGYN, complex family planning specialist. I would love to see this presented at Society of Family Maternal Fetal Medicine meetings or ACOG. I think this needs to be disseminated to OBGYNs as well. I have 2 questions. One is the premature deliveries. It would really be nice to see if that's from maternal reasons or obstetrical reasons. And then also the placental abnormalities, that was quite striking as well. Is that, things like placenta accreta that has a really higher morbidity and mortality related to it, or something like previa where just the placenta is covering the cervix and it necessitates a C-section?
Yeah, no, thank you for all those questions. First, I think we would love to present this data more in an audience of OB-GYN providers, et cetera, because I think it's really important. I think people like you are very well aware, which we appreciate, but there's a lot that are not that I think we would love to see that, and hopefully we can have that on our radar and are actually aiming with the CF Foundation to put some general guidance documents out that we're also hoping will be read by the OB-GYN community more. In terms of your other questions, those are great questions, and we have not yet delved into that data much yet. We do have a lot of granular data that we just tried to figure out how to get on simplified tables, but in terms of details about the placental abnormalities, et cetera, I have to look at exactly what we have, but there is a lot of available data that we just have sort of bulked together right now. But I think we will slowly have that, and we'll probably get your input on how to present that. So thank you.
Congratulations.
I'm Katie Odo-Davis. I'm a biostatistician at Seattle Children's and I'm study. So I don't have a question. I actually just have a caveat that I wanted to share in context with the pregnancy loss. Because people are enrolling throughout pregnancy, we plan at the end of the study to account for that, the timing of gestational age at enrollment. So some people who enroll later, after 20 weeks, it's impossible for them to have a miscarriage during the study. So we need to account for that later. So just context for the
No, that's a great point, Katie. So if anyone didn't hear that, I think one of her points, which was terrific, is that we can enroll people in the study at any point in their pregnancy. So there may be people who are enrolling in the third trimester of pregnancy, et cetera. So again, that can bias information like the pregnancy loss. So thank you for that.
Hi, my name's Dot. I'm an adult physician from the UK. I had two things, if that's all right. One was, I just think it's interesting. I know the person previously asked about preterm and whether or not that's, maternal choice. And I guess similarly, just it will be interesting when you drill down to know whether or not those are the same people who have extended stays in the hospital and the NICU, because it's just, I wonder if it's preemptive. Is it because they're preterm and their physicians are being cautious, or is it actually a complication because the babies are unwell? And I appreciate you don't have that yet, but that would be interesting to see.
No, thank you. That's a good point. And I hope we can drill down into that.
And then I guess something, just because I'm not aware of what the normal population, the general population would look like. For the milestones, I know you said the mean data obviously looks very encouraging. The bottom line of your table, which looked at numbers of infants meeting 100% of their milestones, those numbers looked much lower, but I don't know if maybe that's what the general population figures look like.
Well, I think some of it is that we don't yet have complete data as we go across. The number of N's get smaller as we go. And I think it's really too early to compare that with the general population, because when we get out to that second year, our N's are somewhere between 20 to 40. So I think it's a little bit skewed in the information we have thus far. But thank you for that point.
Great piece of work. Thank you.
I would just add to that, and then personally, that we don't expect 100% of babies to reach the milestone.
Yeah.
So that data is totally fine. So most of the charts, look at 75% of people meeting their babies the milestones, and that's the goal, at least so
Hello, Elke de Wachter, Brussels, Belgium. I have a small question. Did you collect data on newborn screening of all these babies?
We will have data on newborn screening if it's in the baby's chart. So some of this is that the way the study is set up, we are getting some of the data through the mother's chart and through the baby's chart at delivery and through their pediatric visits. But that is part of what we're collecting. How much data we will have on it, we don't know yet, but we should have a fair bit that we hope to be able to share.
Okay, one is pre-modulator data suggested that loss of FEV1 following pregnancy may be actually related to less self-care as opposed to the pregnancy itself. So the data suggesting that the cohort had a maintained FEV1 following pregnancy, does that suggest that the maintenance therapies had been already discontinued? either pre-pregnancy or sort of during pregnancy?
Yeah, so that's a really important question, and part of the reason, that I just wanted to share the raw data is because this has not been analyzed yet in a statistical manner, nor have we incorporated all the variables that should be incorporated. But it is true that historical data, though it varied, has shown a bit of a mild dip in some studies of FEV1, and that is our primary endpoint, but I really hesitate to make any conclusions that ours is maintained because I don't think we really truly know that yet until we have the complete data and have thoughtfully analyzed it.
Okay, and then there are a couple of questions on other outcomes and data that you're collecting. One is on gestational diabetes and return to non-diabetic state versus CFRD, and then one is regarding postnatal data on infant outcomes. Sort of how long will you be following that, and what will you be looking at?
So we are collecting glucose tolerance tests during their pregnancy. If they get a glucose tolerance test post-pregnancy as part of their standard of care, then we will have that information. And then Dr. Putnam is also in a subset of population getting actual continuous glucose monitoring on people during their pregnancy and post-pregnancy. And those will include people with diabetes, impaired glucose tolerance, and without diabetes at all. So that should provide a good amount of data. How much our power will allow us to actually analyze that, I'm not sure yet, but we will have that. And then there was a second question, I think I forgot.
Yes, the postnatal data on infant outcomes, side effects of ETI, and kind of what you'll be monitoring there.
Yeah, so I only shared a subset of some of the infant outcomes that we have. We have a very large spectrum of pretty much capturing anything that occurred. It will be very difficult to attribute any of these directly to a modulator use. There are likely a number of other variables. I think our goal overall is to provide what's happening in the era of modulators, but a study that really talks about the impact of a drug on an infant is really much larger studies that this one is not powered to do. So much of this is just going to be understanding it in the setting of modulators.
And then there was a question about the 7% rate of non-cardiac congenital defects. Is that a little higher than expected? And if so, or if not,
I do not know the general population. Is it? Jen may know more than I do.
Yeah, so it is a bit higher, but that historically has been the case for women with CF, but it's actually been more cardiac. So women with CF did have higher rates of congenital anomalies. And unfortunately, if you look at still happening, but it's not happening at a higher rate. Again, this has been statistically analyzed, but it's pretty consistent with what we know.
Mm-hmm. And what type of congenital issues?
A range, but the biggest thing was cardiac.
Cardiac, yeah. Okay.
In the previous study.
Mm-hmm.
Relatively small n because the number of pregnancies wasn't as high.
Yeah, so
nutritional things, especially in the past, because we don't have good measures, but we'll have blood banks to be able to look at that.
Yeah, so what we reported was the non-cardiac ones, which we'll take a deeper dive into, but just to bucketed them right now.
Yeah.
But I think, as Jen pointed out, for anybody who might be interested in this data, we are banking biosamples from during pregnancy and post-pregnancy in the mothers. And so we encourage that if people have studies they're interested in doing, the CF Foundation is very willing to provide that data for people as a resource to ask through your own study questions.
And any inklings of how mothers are doing if they had more severe lung disease or advanced lung disease?
Yeah, we have not looked at that yet, but we do have that spectrum where I think their FEV1 range from the 20s to the 120s. So we hopefully will be able to take a good look at that because there have been studies that have shown that the baseline lung function impacts the trajectory there forward. So I think we're hoping to answer that question.
I think that's all we have here.
Thank you.
Congratulations.